That has worked on there. So now it's all recording. So let me introduce you to our fantastic guest speaker, Dr. Rebecca Smithson, who will be talking about endometriosis and menopause. Becky, you've come and spoken. In fact, we were just speaking about it just before logging on, that it was January last year you spoke with us. Is that right?
Around about then, yeah,
Yes.
just over a year anyway.
Oh, yeah. Well, thank you, Becky, so much for joining us tonight, and I look forward to hearing this presentation.
Thank you very much, and thank you very much for having me back. I do always feel reassured when I'm invited back, so it means I haven't gone too far wrong first time. So yes, thank you. I'm going to talk a bit about endometriosis and the menopause. My interest being the menopause. You will know a lot more about endometriosis than I do. Oh, oh,
Oh,
oh, oh, there we go. The
hey.
arrows on my computer are working. So I'm just going to run through a few basics first of all, just so that we're all on the same page as far as menopause is concerned. We diagnose the menopause when you've had 1 year after your last period. So it's a retrospective diagnosis. The years up until that point are the perimenopause, and they can often be, for some people, the most symptomatic years. The average age of the menopause is 51. However, you can go through the menopause earlier or indeed later. About 80% of people have stopped their periods at the age of 54, but that does mean that 20% of women are still bleeding at the age of 54. About 1% of women go through a premature menopause. That's when the menopause happens under the age of 40. So there's a really broad spectrum of ages that it can happen at. There's also a broad spectrum of how long it lasts for. The quoted average is about 4 to 7 years worth of symptoms. There are some people, about 20% of women seem to sail through it with very, very few symptoms. About 20% of women have really difficult, challenging, life-changing symptoms. But everybody experiences some symptoms, but for differing lengths of time. You can have some people who just seem to have symptoms for a year or two. You can have some people still experiencing the flushes and sweats, what we call the vasomotor symptoms, well into their 70s. And that can run in families, although it doesn't always. The best advice I can give, if you are able to speak to a female relative, then sometimes you can get a hint of what's in store for you. Now we have estrogen receptors throughout our bodies, and that means we can have symptoms pretty much anywhere. The list goes on and on and on. Of course, there are the symptoms that we've all heard about. So most people think about their periods stopping, but they can become heavier, lighter, closer together, further apart, more prolonged. And it can be a mixture of all of those things. So you might have some months that are short and light and some months that are heavy and long, and you don't really know where you are with them until they stop. Most people also know about those vasomotor symptoms as well, the hot flushes and night sweats, but in fact, some people get cold chills rather than hot sweats. The mood symptoms of the menopause are really common, and they often start to present for a lot of people at around about the mid-40s. And it's not uncommon for some people to be put on antidepressants, for example, without actually, pressed the wrong button, without actually being having discussed with them whether or not this could be the menopause. But that can be anxiety, low mood, rage, that sort of thing. It's quite common. If you've read the Davina McCall book, she talks about suddenly finding herself petrified of driving places. And that's actually one that I've come across quite a few times. People just find themselves, they may have been perfectly confident drivers before, suddenly find themselves having difficulties driving to new places or to places that they've driven to for years and years and years. Things like food intolerances can become more common, changes to the gastrointestinal tract. Sorry, I'm just looking at the chat at the same time. Yes, cold chills, absolutely. Changes to like bloating. Some people get constipated, some people get diarrhea. Tinnitus is a relatively common one. Palpitations, very common. Obviously, if you get palpitations, make sure you get that checked out. Don't just assume that it's to do with the menopause. the symptoms that we often don't talk about are things like the genitourinary symptoms. And anybody who tuned in last time knows I can get a little bit exercise talking about the pelvic symptoms. Really important to be aware of these symptoms, though. They tend to be more medium to long-term symptoms of the menopause, so you may not get them at the time of the perimenopause. It might be more your mid-50s, 60s when you start to develop symptoms like dryness, soreness, problems with recurrent bladder infections. And one of my many bugbears is women in their kind of mid to late 50s being put on repeated courses of antibiotics for urinary infections without anybody taking a look at the vaginal tissues, seeing that they're dry and thinking, would some vaginal estrogen help here? Because it usually does. There is a big cultural variation in symptoms. So, for example, Afro-Caribbean women tend to experience much longer duration of symptoms. That's not entirely unexpected. Anybody who reads, actually, when you read things like Gabor Mate and books like that will know that people living with really institutionalized endemic racism tend to have higher rates of inflammation and will then therefore tend to have greater symptom burden. There's a big overlap between the symptoms of stress and the symptoms of menopause. We know that menopause makes stress worse. We know that stress makes menopause symptoms worse. So anybody living under a lot of stress will tend to have worse and potentially prolonged symptoms of the menopause. We think that people in the Asian continent tend to have lower reported symptoms of menopause. Some of that is cultural. Elders are generally more respected in those cultures, but they also have diets that are quite rich in phytoestrogens, so the plant estrogen sources. So, sorry, I'm just having a look at the chat bar again. Interesting, good. So lots of differences. People who are from some cultures where women's health isn't talked about very much are encouraged to see the menopause as something that they keep under wraps. And so we don't really know what reported symptoms may be in those countries. Now you have different types of menopause. So the majority of women will go through a natural or spontaneous menopause. That's just when the ovaries have run out of eggs. You are born with a certain number of eggs in your ovaries and they are released over time and eventually you run out. And as you run out, the levels of hormones, estrogen and progesterone, fluctuate wildly all over the place. It's a bit like a roller coaster. Sometimes they're up here, sometimes they're down there, sometimes they're over there. And that's really, really difficult because you just don't know day to day or even within a day where your hormone levels are going to be. You can also have an induced or secondary menopause. So for people with endometriosis, you'll be aware of the GnRH analogues, things like decapeptyl, the things that induce menopause to try and quieten down endometriosis symptoms. Certain types of chemotherapy, pelvic radiotherapy can also be associated with an induced menopause. And we often find that people who are plunged into menopause like that, particularly if they've perhaps started at an earlier age, so their hormones were maybe a bit higher, plunged into that secondary menopause without the sort of fluctuations on the way to allow their body to get used to it, very often they have worse symptoms. And it's really important that anybody going for any of these treatments has a game plan in place and understands what to expect and what's going to be done about it. I think that doctors are getting better at doing that. Historically, they were pretty poor at that. I think we found quite a lot of women who perhaps had their ovaries removed weren't warned what to expect, weren't talked to about HRT or alternatives to HRT. So I think we're better than we were, but there's always room for improvement, I'm sure. So I'm going to talk to you now a little bit about HRT, hormone replacement therapy. There are different types of HRT. There's estrogen only, and there's estrogen and progesterone combined. The basic rule of thumb is that if you have a womb, you need progesterone. Estrogen causes a thickening of the lining of the womb. Progesterone counteracts that. But we are going to come back to that because that's more complicated than it sounds, actually. There is sequential and continuous combined. Sequential is the bleed version of HRT, so that's for people who are still having periods. If you are 1 year post your last period, You can go on to continuous combined. That's where you have the progesterone continually, and that way you don't have a period, because what we don't want is for you to stop having periods and then suddenly go back to having periods. Who wants that? There are different ways of taking HRT. You can take it orally as a capsule. You can take it through the skin. The progesterone component can be supplied by the Mirena coil. There is one type, or a couple of types of progesterone that you can use off license as a pessary, but it is recommended by the British Menopause Society. So though it's off license, it is done. I'm terribly sorry if you can hear the mad collie puppy barking in the background. It's being stirred up by the teenagers. My apologies. And there's also topical estrogen. So for those vaginal pelvic symptoms, using topical estrogen can work really well. And sometimes people who are on systemic HRT don't get enough estrogen for those pelvic tissues and need topical estrogen on top, and there is no problem with that. Now, last time I was here, I was having a look at my slides, and I put this slide up last time just to talk about the evidence. I know you haven't come here for a lecture on how poor the evidence is in women's health. We all know that there's an endemic gender bias in healthcare research. Women have been systematically excluded from healthcare research, partly because our pesky cycles made it difficult to work out whether or not, say, the effect of a drug was due to that drug or whether we were just being hormonal. So they just excluded us. There was also exclusions, for example, in America, in the wake of the thalidomide scandal, women were routinely excluded because they didn't want to expose any pregnancies to medications, which you can kind of understand. However, it's taken a while for the scientific community to catch up, and I think that we're still seeing that there really isn't great research into women's health. That said, what I found interesting was I revisited these stats. You'll remember that male pattern baldness was way up there and well higher than anything that looked at menopause and endometriosis together. But in the last 5 years, there maybe has been a bit of a catch up. There has been more things that have been published, but you'll see that again, things that are published that are tying research together between people with endometriosis and the menopause is still really sorely lacking. I'm just going to break off to have a look at the chat bubble again. Thank you. So we're still lacking good evidence. Why does good evidence matter? It matters because we need to know that what we're recommending to people is the right thing. Now, I mentioned earlier that estrogen causes the lining of the womb to thicken. If you do nothing about that, then over time, that increases your risk of developing cancer of the womb. Taking progesterone protects the lining of the womb, but we think that it's the progesterone in HRT that increases your risk of developing breast cancer over time. So it's always a balance between the risks and benefits of the two. Now, if you're somebody with endometriosis and you've had a hysterectomy, what happens if you've got endometriotic tissue elsewhere in your body? That's really, really important. And one of the studies that's been published in the last year, one of those 4 that was picked out in the previous slides, did point out that still there are no large long-term studies comparing the effect of continuous or sequential progesterones on the recurrence or malignant transformation of endometriotic tissue. So that means going on HRT after a clearance of endometriosis carries a risk of recurrence. Going on estrogen-only HRT without the progesterone to counteract it carries a risk of eventually thickening that endometriotic tissue with the risk of potentially malignant transformation. And malignant transformation means something turning into cancer. As far as reactivation of endometriosis is concerned, it's more likely with unopposed estrogen. It happens, it doesn't seem to matter what type of progestogen you're on. It seems to happen with all of the progestogens if you're on combined HRT. The site of recurrence is most likely to be the pelvis, unsurprisingly. And the evidence isn't great, but it doesn't look as if delaying HRT after surgery reduces the risk of reactivation. It's not a huge risk, but it is a possibility, and you have to bear that in mind. If you've gone through surgery to clear your endometriosis, if you've had your ovaries taken away and you've been plunged into that surgical menopause, you do have to weigh up the pros and cons of going on to HRT. Again, the evidence about malignant transformation in endometriotic tissue is poor. It does happen. There are cases of it. But what we can't say is what the risk is. There's not enough evidence to say that there is a percentage risk that is, 5% or 10% or whatever. What we can say is that unopposed estrogen seems to carry some risk of malignant transformation if there is residual endometriotic tissue somewhere in the body and you give estrogen-only HRT without the progesterone to back it up. One study suggested Tibolone might be better than the rest, but again, it was a fairly poor study, so we can't be absolutely sure. And as I said before, we have to be careful about the risk of breast cancer. When we talk about HRT, the thing that women always worry about tends to be the risk of breast cancer. And that's because there was a couple of really big studies 20 years ago that came out and were splashed all over the press that basically said, the Daily Mail headline was basically, take HRT and you will die of breast cancer. One of those studies was so rubbish we don't even look at it anymore. The other study was better designed, but nonetheless had issues. And one of those issues was that the type of estrogen in that study was one that we weren't even using in this country 20 years ago, let alone now. That was Premarin, the one that's taken from pregnant mare's urine. It's not a body identical estrogen. All of the estrogens that we use in this country are body identical, and that means they're as close to what the body naturally produces as we can manufacture. They're taken from plants like soy and yam. Progestogens are a bit different. There's progestogens that are a bit more synthetic. There is a progesterone. I won't bore you with why we call some of them progestogens and some of them progesterones. But anyway, there are some body identical progesterones like Utrogestin. They appear to be lower risk. But the point being that the best evidence that we have to date, and as Theo said at the start, this is correct as of today and may be different if a different study comes out next week. But it's illustrated here in this wonderful picture. This is taken from the Women's Health Concern website, which is the patient arm of the British Menopause Society. And if you're trying to find any information out about HRT, I would thoroughly recommend that you go to this website. They are very balanced, very sensible, very measured. What this picture shows in the top line of blue ladies, I'm pointing to my screen like you can see where my finger's going. You really can't, but hopefully you can at least see the blue ladies on your screen. If you take 1,000 women aged 50 to 59 and you follow them up over 5 years, this is just 1,000 women, no increased risk of breast cancer, not on HRT, just ordinary members of the public. Over 5 years, the risk of them being diagnosed with breast cancer is 23 per 1,000 of those women. So statistically, 23 women over 5 years will be diagnosed with breast cancer. That is the background risk of breast cancer in the UK. Sounds like quite a lot, 23 in 1,000 women. It is a very commonly diagnosed cancer in the UK. Remember, this only applies to women aged 50 to 59, though. If you're going through, for example, an induced menopause under the age of 50, what we think is we're just giving you your hormones back and we are not increasing your risk of breast cancer. But for 50 to 59, this is the best evidence that we have. Now, if you take those same 1,000 women and you put them all onto combined HRT, so that's the estrogen with progesterone, and you follow them up for 5 years, statistically, you would get an extra 4 cases of breast cancer diagnosed. What you don't see is an increased death rate of women from breast cancer. And what we think is happening is that the progesterones are just increasing the rate of growth of cancers that were maybe already there, but teeny tiny and weren't ever going to be diagnosed and weren't going to cause the woman any problems. Interestingly, the statistics show that if you put the same 1,000 women on estrogen only HRT, statistically, you would get 4 fewer cases of breast cancer diagnosed over those 5 years. So estrogen is very important in women who have an already diagnosed estrogen-dependent breast cancer, but it appears to be the progestogen or the progesterone that is causing new diagnoses of breast cancer. I hope that makes sense. Do put something in the chat bar if I'm losing you. What's really important to note, though, is in the other pictures, if you put those same 1,000 women, oh, I've got somebody in the chat bar, hold on a moment. One of my worries is that because I'm stage 4, I know the disease is systemic. Is it okay if I come back to that when we're not recording and we can chat through it? Is that all right? Looking at things like if you were to go onto the combined pill and you would follow those 1,000 women up for 5 years, statistically, you would still get an extra 4 cases of breast cancer diagnosed over the next 5 years. If those same 1,000 women drank 2 or more units of alcohol per day, you'd get an extra 5 cases of breast cancer diagnosed over the next 5 years. If they were all smokers, they increased the rate of diagnosis by 3 per 1,000 women. If their BMI was 30 or greater, then they increased their risk by 24. So what I usually say to my patients is, risk is very subjective, and what is high risk to one person is not high risk to another person. You know, if your best friend died of breast cancer, you might think that a risk of 4 per 1,000 is quite high. If you've never known anybody to have any cancer, you might not think that that's a great risk. But if someone's menopause is making them feel utterly miserable, they're coming home at the end of the day and comforting themselves with a donut, a glass of wine, and a fag, and their BMI goes up and they haven't got the motivation or the energy to be able to modify their lifestyle, then actually they're probably increasing their risk by more than they would by taking HRT if the HRT addressed their symptoms sufficiently that they gained the motivation to be able to look at their lifestyle. What's important is that we don't look at HRT in isolation. It's not a magic wand. If you take HRT, you still need to address your lifestyle factors, and that's really, really important. And someone's put in the chat bar that Utrogestin help them sleep. Yeah, progestogens are sedating, so we tell people to take Utrogestin at night because it will make you quite sleepy. They're quite handy that way. So anyway, the point of this is that it's a balancing act, particularly for people with endometriosis. What we don't want to do is give you unopposed estrogen and increase the risk of endometrial cancer from your endometriotic deposits. But what we don't want to do also is reactivate your endometriosis. But we also have to balance that against the risk from the progesterones as far as breast cancer is concerned. So it has to be a really individualized conversation. It does depend a little bit on what stage endometriosis you have. And what the British Menopause Society says is that I'll let you read the first paragraph yourself. And the second paragraph says a pragmatic approach may be used to guide practice, to which I say, well, what does that mean? And what it means is there is no answer. There's no right or wrong. You should never compare yourself to anybody else. All we can do is carefully discuss and balance the risks and benefits for each individual person, and that will be different for everybody. HRT and the menopause should always be an individualized approach, no matter what. But it is that much more complicated for people who have endometriosis, unfortunately. So in summary, the evidence is rubbish. We don't really know what to do. This is your answer, Theo. We don't really know the answer. We don't really know what it means. We just have to try and work out the best way forward for each individual person. And it's going to depend a little bit on how severe your endometriosis is, whether you've had any surgery to remove it, what your other risk factors for developing issues such as breast cancer are, what your personal thoughts are around HRT, and what else might be done. Because HRT, as I said, it's not a magic wand, and it's not for everybody. Not everybody wants to go on it, not everybody can go on it, and not everybody who goes on it gets on terribly well with it. For some people, it can be life-changing and really, really helpful. Other people go on it and just go, nah. There are other options though, and this is really important. Sometimes it can feel like discussing the menopause is a question of HRT or nothing, and that's not the case. So if you have the vasomotor symptoms, the hot flushes and night sweats, we sometimes use drugs like the antidepressants. That's not saying that we're treating depression because you've got hot flushes and they're making you depressed, or your depression is making you think your hot flushes are worse than they are, or anything like that. It's because these drugs actually help with hot flushes. We discovered that in women who had breast cancer who were depressed, their treatment for breast cancer was also giving them hot flushes, but they were being treated for depression with these antidepressants. And they said, well, my mood is or isn't any better, but strangely enough, my hot flushes have improved. There are other drugs like clonidine. Gabapentin is a pretty strong one to be using for hot flushes, but they do exist. The mood disorder of the menopause is being caused by estrogen, primarily estrogen, but estrogen and progesterone and possibly a bit of testosterone in there as well. Therefore, the best and most effective treatment for the mood disorder of the menopause is HRT. But as I said, not everybody can, not everybody wants to go on HRT. And for some people, it doesn't do enough for their mood. So some people take antidepressants for the mood disorder of the HRT, but it's important to know that they should never be first line. Discuss the alternatives first. For the pelvic symptoms, lubricants, moisturizers, vaginal estrogens. So lubricants you use around the time of intercourse to make things less dry. Moisturizers are very much like the moisturizers that you use anywhere else in the body, except don't use the moisturizers for any other bit of the body down there. Really not good. There are specific moisturizers for that bit of the body. Use them every day. And there's different ones. There's ones that have phytoestrogens in, and they just plump up the tissues and make them a bit more moist. Vaginal estrogens are very safe. We think that about a year's worth of treatment with vaginal estrogen is approximately equivalent to the same amount of estrogen as you get from taking one oral HRT tablet. So it's very, very low doses. Not very many people who can't take vaginal estrogen. And as I said earlier, some people, even though they're on systemic HRT, still need the vaginal estrogen on top because it just isn't quite enough to control their symptoms. Oh, my mouse disappeared for a second there. Really important to think about your bones, especially if you go through an early or premature menopause. So getting outside in the daylight, really important so you get enough vitamin D. Sometimes supplementing that with tablets and thinking about things like bisphosphonates to protect your bones if you need to. 1 in 3 women suffer from osteoporosis, and that's very definitely increased if you go through an early menopause. So worth thinking about your bones. But new for 2024 is a new tablet called Veoza. Veoza is the brand name. The actual name of the chemical is fezolinetant. So you can see why they called it Veoza, because it's easier to say. You have a thermostat in your brain, and it works directly on that. It is entirely non-hormonal. And it seems to be really quite effective, actually, for hot flushes and night sweats. If you have fairly mild hot flushes and night sweats, it seems to be less effective. But for those people who have moderate to severe hot flushes and night sweats, it seems to work reasonably well. Oh, I see there's a question about this drug, in fact, in the chat bar. Interestingly, in the studies, they excluded women who had cancer of any sort, a history of cancer of any sort, but they also excluded women who had any particular health diagnoses. So I don't believe that it has been studied in women with endometriosis. But scientifically speaking, I can't see a particular reason why someone with endometriosis wouldn't be able to take Veoza. It works on neurokinin 3 antagonists. I can't see that having an effect, but it hasn't been studied, so we can't be absolutely sure. Because they excluded women with breast cancer, they've said it is contraindicated in women who have current breast cancer, but could be considered off license after careful discussion in women who maybe have a history of breast cancer in the past. It's not been studied on women on HRT, so at the moment it is contraindicated. So if HRT isn't sufficient to control someone's hot sweats, they're not allowed to have it. And anybody who has underlying liver disorders need to be aware that the drug can affect their liver. It is expensive. It's not available on the NHS at the moment. You can buy it. I don't know if I should say that, but you can buy it from online pharmacies in the UK. It costs around about £80 a month, depending on the pharmacy that you get it from. We are expecting a decision possibly late summer about whether it's going to be allowed on the NHS. But at the moment, it is not allowed. But I have come across people who have been seen by NHS gynecologists and menopause specialists who have been recommended that this would help them, and if they can afford it, to buy it online. I think for me, though, the really big thing about Veoza is that it's new, and that means that we are doing research into new treatments. And we are doing research into treatments that aren't just HRT, and that's enormously exciting. Whatever you think about Veoza, I think it's okay. I think it has a place. but it's only going to treat the vasomotor symptoms. It's not going to treat any other symptom of the menopause. But at least we're doing that research, and that gives me hope that more new treatments will be available in the near future. It's not all about drugs, though. There are other things that you can use. There are the phytoestrogens, the plant estrogens. Just be aware that they are weakly estrogenic. So everything that I have said about estrogen is true about phytoestrogens too, just on a much smaller scale. If you're going to take herbal supplements, make sure that they have the traditional herbal registration logo on them so that you know that you're actually taking what they say is in it. I'm not a big one for supplements. I think eat a healthy diet and you'll get the majority of what your body needs, so long as your gut functions well enough to be able to absorb it. I do recommend vitamin D, particularly in the winter months. In this country, we simply can't absorb enough from the daylight in the winter months. I think we're still in winter at the moment, as far as I can tell. Perpetual winter, perhaps. And magnesium's the only one that I think about. I mean, you can get magnesium, obviously, from your diet quite happily, but it is one that is quite good for aches and pains, for sleep and for mood, as long as you get the right one. There are about 12 different magnesium compounds, and some of them, like magnesium sulfate, are really good for constipation. And if you're not constipated, I wouldn't take it. But there are other ones like magnesium glycinate, you know, they're quite good. And if you want, you can chuck some Epsom salts in the bath. They've got magnesium in. How much you absorb through your skin, I don't know, but having a bath is a nice, relaxing thing to do. Chuck some Epsom salts in. I'm a big believer in the importance of supporting your gut, feeding your microbiome, lots of plant food, lots of seeds, lots of fiber, lots of legumes, lots of beans, that sort of thing, to feed the diversity of your bugs. Or is actually by your, rather than your brain, it comes from foods that you eat. For myself, I practice CBT, acupuncture, hypnotherapy. Ruth Devlin, who's come to talk to you before, she does reflexology. Stress is really, really important in the menopause, as I said, and anything that you can do to reduce your stress levels. Good for you, Louise. I think that's brilliant. Anything you can do to reduce your stress levels is really, really helpful. Exercise, it doesn't have to be going for a run. If you move your muscles, they release myokines, which are anti-inflammatory. So just take the washing upstairs in 3 bundles instead of 1. Get up from your desk every hour to take 250 steps. Keep your body moving. Switch the radio on and have a dance when no one's looking. Whatever your form of exercise is, but keeping your body moving a bit is really, really good for it. And sleep is massively important. We've had a little bit of chat in the chat bubble about sleep. And that's very important for your well-being. If you lack sleep, you'll tend to crave carbs. If you eat carbs, you'll get a sugar rush and then a crash in your sugar. And then you'll get a release of your stress hormones to try and bring your blood sugar up. So you'll feel more stressed. More stress makes you crave more carbs. It's a vicious circle. We will come back to sleep in a later slide though. Stress is very important in the menopause for lots of reasons, but one of the reasons is in the hot flushes and night sweats. So I've mentioned the thermostat in the brain before when we were talking about Veoza. You can imagine it like between those yellow lines on the slide there. That's what's called your thermoneutral zone. If your body's within that yellow line, it manages its temperature without you even noticing. So you get a little bit hot and the capillaries come to the surface of the skin. You get a little bit cold, your hair's standing end. You don't really notice it happening. You don't feel anything. But if your body temperature goes out with those yellow lines, out with the thermoneutral zone, then you get symptoms. You get cold and shivery, you get hot and sweaty. And in the menopause, with a lack of estrogen, what happens is that thermoneutral zone narrows, so it's much easier to be pushed out into a hot flush or a cold chill. But other things also narrow your thermoneutral zone. Stress being a big one. Caffeine, nicotine, alcohol, quick release carbs like sweeties. I used to work with someone who said every time she had a jelly baby, she had a hot flush within about half an hour. So what you can find is that because stress has a big impact, you might say have a cup of coffee on a Monday morning and have a terrible sweat, but have a cup of coffee on a Saturday morning when you're not at work and actually you get on fine. So thinking about the things that you can adapt in your environment that might just reduce your stress levels may reduce the impact of your symptoms on you. And sleep, this is one of my most favorite slides in the world. I get a bit boring about it. I do apologize. But it's really important. This is your sleep cycle. What happens when you go to sleep is you cycle through deep and lighter sleep. So your deepest sleep is stage 4. Your lightest sleep is REM sleep, and that's the rapid eye movement sleep, or REM sleep. Every 90 minutes or so, you cycle through this down into deep sleep, up into REM sleep, down into deep sleep, up into REM sleep. And you spend more time comparatively at the end of the night in the lighter sleep, more time in the deeper sleep at the beginning of the night. Every time you hit that REM sleep, you're very close to the surface. And it's very easy just to tip over into wakefulness whenever you reach that point. So sometimes people say, you know, I'm a terrible sleeper. I wake up 3-4 times a night. You're not a terrible sleeper. You're a perfectly normal sleeper. You're just tipping into wakefulness and remembering it, whereas someone else might not remember it, just turn over and go back to sleep. As long as you get back to sleep, it's fine. But that people wake up and they look at their phone. Do I always and remember? So then go back and open the phone, start scrolling or looking at Facebook or whatever, get more. You know, am I back?
Yeah, you're back.
I'm back. Oh, good. Jolly good. Sorry about that. I blame the teenagers on their computers. What was the last thing I said that you heard? Put you on the spot.
About the REM, I think is the last. That's going with brain
Okay.
fog, though.
Had I stormed to the window yet? No. Okay.
No,
So,
no.
So if you have that waking up at 2 o'clock in the morning and you get really frustrated about the fact that you've woken up, and then your thermoneutral zone narrows and you have a hot flush and you storm over to the window, and then you go back to bed and you start doom scrolling, it's very, very, very difficult to get back to sleep. Whereas if you bear this picture in mind and you say, actually waking up overnight is really, really common and normal, and it just means that I've had a really nice 1 or 2 normal sleep cycles, which means I have had that deep sleep and I have had that REM sleep. And that means even if I don't get back to sleep tomorrow, I've had sleep, so it's not going to be a disaster tomorrow, but I may well just lie here nice and relaxed and go back to sleep. It's that frustration and tension that stops you from getting back to sleep. Whereas if you're more understanding of the sleep cycle and more relaxed about it, you'll tend to get back to sleep because you have relaxed. And sleep is so important. Well, it's important for everything. It's not just the menopause, but it's so important to try and get a good night's sleep. Although try is the wrong word, actually. The more you try to sleep, the less you'll be able to sleep. The whole point about sleep is to try and relax and let it come. I just read Michael Mosley's book on sleep, Fast Asleep or something, and that's a really good book. And that looks at the cognitive behavioral therapy aspects of sleep, which is really, really useful. So anybody who's struggling with sleep, I would thoroughly recommend they get that book. It's brilliant. And I think you'll be relieved to hear that's it from me.